We're tackling anti-inflammatory agents.
That's right.
We've got a pretty solid set of materials here, and, well, our aim is to really cut through the complexity, get to the heart of how these drugs work, the different kinds, and why it all matters. Think of it as your clear guide through this important topic.
Exactly. It's a big area, so we'll be looking at, the conditions they treat, the main categories, everything from household names to the newer biologics.
Right.
And then how they actually work inside the body, what the body does to them, the potential downsides.
The adverse effects.
Yes, adverse effects, when not to use them, how they mix with other drugs, dosages, toxicity, and some key warnings, too. A lot to cover.
Okay, sounds good. Let's jump right in. Where do these agents actually get used? Seems like they crop up quite a bit.
They really do. We can sort of group their uses. First off, you've got the, let's say, classic inflammatory diseases, like rheumatoid arthritis, osteoarthritis, gout. For those, you're often looking at things like NSAIDs, maybe corticosteroids.
Right, the ones most people have probably heard of. And then you mentioned autoimmune conditions.
Yes, exactly. For things like lupus or inflammatory bowel disease, the approach might involve DMARDs, that's disease-modifying anti-rheumatic drugs, or maybe the biologics we mentioned.
So different tools depending on how the immune system is involved, basically.
Precisely. It shows how inflammation driven by the immune system needs sometimes a more targeted approach.
What about more sort of immediate inflammation, like after an injury?
Good point. For that acute inflammation, say post-injury or post-surgery, NSAIDs are very common. They help with the pain, the swelling.
Makes sense.
Sometimes colchicine might pop up there too, particularly in certain situations like gout flares, but sometimes beyond that.
Got it. And allergies are on the list too, asthma, things like that.
That's right. Corticosteroids are really key for reducing airway inflammation in asthma or allergic rhinitis. Now, antihistamines are common in allergies too, of course, but they work differently, not primarily by tackling the inflammation itself in the same way.
Okay, so corticosteroids are the main inflammation fighters there. And lastly, skin issues. Eczema, psoriasis.
Yep, for skin inflammation, topical corticosteroids, creams, ointments are often the go-to. Sometimes other things like calcineurin inhibitors might be used too.
Wow, okay, so really a very broad range of applications. It underlines just how central inflammation is to so many health problems.
It really does.
So now we know where they're used. Let's get to know the players better, the different types of anti-inflammatory agents.
Right. We can break them down into a few main groups. First, the NSAIDs, non-steroidal anti-inflammatory drugs.
Like ibuprofen.
Exactly. Ibuprofen is a perfect example. Diclofenac is another common one. Now, the interesting thing is how they work. Ibuprofen, for instance, it blocks two enzymes, COX-1 and COX-2. Think of these COX enzymes as like little factories making prostaglandin substances that signal pain and inflammation. Blocking them helps, obviously, but blocking COX-1 can also affect the stomach lining. That's where the ulcer risk comes in sometimes.
Ah, I see. So it's a bit of a double-edged sword.
It can be. Diclofenac is a bit more geared towards COX-2, but there's still caution needed, especially regarding cardiovascular health.
So even within that one family, NSAIDs, there are nuances. What's the next category?
Next up are the corticosteroids. Think prednisone, hydrocortisone. Prednisone is often used for more systemic, body-wide inflammation. But, and this is important, long-term use needs care because it can suppress the adrenal glands, which make our body's natural steroids.
Right. That sounds like something you definitely need to manage carefully.
Absolutely. Tapering off slowly is key. Then we have the DMARDs, disease-modifying anti-rheumatic drugs.
Okay.
Methotrexate and sulfasalazine are common examples here. These tend to work more slowly, aiming to modify the underlying disease process itself, especially in those autoimmune conditions.
So they're not just symptom relief, they're trying to change the disease course, like a long-term strategy.
Exactly right, playing the long game. And then moving into more, let's say, advanced therapies, we have the biologics.
Right, the newer ones.
Like adalimumab. This is a TNF-alpha inhibitor. TNF-alpha is a specific protein, a cytokine, that really drives inflammation in conditions like rheumatoid arthritis or psoriasis. So adalimumab specifically targets and neutralizes that protein.
That sounds much more targeted, like a precision strike, you said?
It really is compared to, say, corticosteroids, which have broader effects. We also have a specific class called COX-2 inhibitors, like celecoxib.
Ah, yes, you mentioned TOX2 earlier.
Right. These were developed specifically to target COX-2 more than COX-1, hoping to, reduce those stomach side effects we see with traditional NSAIDs.
Did it work? Less stomach trouble.
Generally, yes, but then concerns emerged about cardiovascular risk, which we definitely need to talk more about.
Okay, so it's always this balance, isn't it? A trade-off. What else is there?
Well, there's a sort of other category. This includes drugs like colchicine, which is mainly known for treating gout flares, and allopurinol, which is actually used more to prevent gout attacks by lowering uric acid.
Got it. Okay, that's a really helpful overview of the different types. Now let's dig into how they actually work, the mechanisms of action.
Right, the science bit. So NSAIDs, as we said, inhibit CAROX1 and/or CAROX2. These enzymes make prostaglandins. Prostaglandins are like local chemical messengers that trigger pain, fever, inflammation.
Alarm signals?
Yeah, good analogy. Alarm signals. NSAIDs basically switch off those signals.
Less signal, less inflammation, less pain. Makes sense. What about corticosteroids like prednisone?
Corticosteroids work quite differently. They actually go inside cells and bind to specific receptors, glucocorticoid receptors. This binding ultimately dials down the activity of a key inflammatory switch called NF-kappa B.
NF-kappa B.
Yeah, it's a major regulator that turns on genes involved in making inflammatory substances, like cytokines. So corticosteroids suppress that whole production line. It's a much broader effect.
So less like silencing a specific alarm, more like calming down the whole control room.
That's a pretty good way to think about it, yes. Now, DMARD-DARs, let's take methotrexate as the example.
Yeah.
It worked by interfering with an enzyme called dihydrofolate reductase.
Okay.
This enzyme is essential for cells, especially rapidly dividing ones like immune cells, to make DNA and RNA precursors. By inhibiting it, methotrexate slows down the proliferation, the multiplication of those overactive lymphocytes involved in autoimmune diseases.
So it's targeting the rapid growth of those problem immune cells.
Exactly, limiting the army, as it were. And the biologics, like adalimumab targeting TNF-alpha.
Right.
TNF-alpha is a specific cytokine, one of those messenger proteins. It's a really potent pro-inflammatory signal, especially in joints in rheumatoid arthritis. Adalimumab basically acts like an antibody that grabs onto TNF-alpha and neutralizes it, preventing it from delivering its inflammatory message.
Intercepting the message, very specific.
Very specific. And then colchicine, for gout. Its mechanism is quite unique, too. It inhibits something called microtubule polymerization.
Microtubules.
Yeah.
Like the cell's internal skeleton.
Sort of, yes. They're crucial for cell shape and movement. By disrupting them in neutrophils, those are the white blood cells that rush into the joint in a gout attack. Colchicine makes it harder for them to move and release inflammatory stuff.
Wow. Okay, it's fascinating how many different ways there are to tackle inflammation. Blocking signals, suppressing the whole system, stopping cell growth, intercepting specific messages, even hindering cell movement.
It really highlights the complexity of inflammation itself. And understanding these different mechanisms helps explain why one drug might work better for one condition than another. Oh, and it's worth mentioning, with steroids especially, long-term use can sometimes lead to resistance. The body might downregulate those glucocorticoid receptors, making the drug less effective over time.
Interesting, the body adapting. Okay, so now we know how they work. What about their journey through the body? Pharmacokinetics. How quickly do they act? How are they processed?
Right, this is all about absorption, distribution, metabolism, excretion. It tells us about onset of action, how long they last. Take ibuprofen orally. You usually feel it start working in about, say, 30 minutes.
Pretty quick.
Yeah. It's mainly metabolized, broken down in the liver, specifically by an enzyme called CYP2C9, and then the kidneys handle most of the excretion, getting rid of it in urine.
Okay, liver and kidneys doing the work. How about prednisone?
Prednisone, also usually taken orally, takes a bit longer to kick in, maybe 1 to 2 hours. It also gets processed in the liver, actually. It gets converted into its active form, prednisolone, there and then, again, primarily excreted by the kidneys.
Similar pathway, slightly slower start. Methotrexate.
Methotrexate, when taken orally for something like RA, also has an onset around 1 to 2 hours. Its metabolism is a bit different, involves something called polyglutamation in the liver, and about 70% gets cleared out by the kidneys. Renal function is really important for methotrexate.
Okay, and what about an injectable biologic like adalimumab? That must be different.
It is. Because it's injected under the skin, subcutaneous injection, its onset is much slower. You're looking at maybe 2 to 4 weeks to see the main therapeutic effects building up.
Weeks.
Yeah. And its breakdown isn't tied to one organ like the liver in the same way. It's broken down more generally by proteolytic degradation, enzymes throughout the body, and cleared via the reticuloendothelial system, part of the immune system.
That makes sense given it's a large protein molecule, so very different profiles in terms of how quickly they work and how they leave the body.
Absolutely. And that affects dosing frequency, choice of drug for acute versus chronic conditions.
Yeah.
It's all interconnected.
Right. Now let's talk about the other side of the coin, adverse effects. The potential downsides.
Yes, crucial topic. With NSAIDs, the big ones are often gastrointestinal ulcers, bleeding. We touched on why. Blocking KOX1 reduces that protective prostaglandin effect in the stomach lining.
So what can be done about that?
Often, doctors will prescribe a proton pump inhibitor, like omeprazole, alongside the NSAID to protect the stomach. Another NSAID issue can be cardiovascular things like increased blood pressure, sometimes fluid retention. This is thought to relate to effects on prostaglandins in the kidneys. Sometimes switching to a more KOX2 selective agent might be considered, but then you have the other cardiovascular risks.
Right, the COX2 specific risks. Okay, what about corticosteroids?
With steroids, a major concern, especially with longer use or higher doses, is immunosuppression. Lowering the inflammatory response also lowers the immune defense against infections.
So more susceptible to getting sick.
Potentially, yes. Careful monitoring for infections is key. Another big one with long-term steroid use is osteoporosis bone thinning. They affect calcium absorption and bone turnover.
So brittle bones, how is that managed?
Calcium and vitamin D supplementation is often recommended, along with bone density monitoring in some cases.
Okay, important long-term considerations. And methotrexate, you mentioned liver issues earlier.
Yes, hepatotoxicity is a known risk. It's thought to relate partly to folate depletion. That's why folic acid supplementation is almost always given alongside methotrexate. It helps mitigate some side effects, including liver issues and mouth sores. Regular blood tests to check liver enzymes are standard practice.
So monitoring and preventative steps are really built into the use of these drugs.
They have to be. Understanding the risks allows for strategies to minimize them.
Okay, which leads nicely into contraindications, situations where these drugs just shouldn't be used.
Right. Some are absolute no-goes, others are more relative, needing careful consideration. For NSAIDs, an absolute contraindication would be someone with an active peptic ulcer, or someone with known aspirin-exacerbated respiratory disease, basically, severe asthma triggered by aspirin or NSAIDs.
Definitely avoid them then. Methotrexate.
Absolute contraindications for methotrexate include pregnancy, it can cause serious birth defects and severe pre-existing liver disease, also severe kidney impairment.
Very clear cutoffs there. Are there situations where it's more of a caution?
Yes. For corticosteroids, a relative contraindication might be a widespread systemic fungal infection, as the steroids could make it much worse. For biologics, like the TNF inhibitors, active infections like tuberculosis or even hepatitis B are major concerns. The biologic could suppress the immune system enough to allow these dormant infections to reactivate. Screening before starting is essential.
So it's not just the drug, it's the whole patient picture, their current health, other conditions.
Absolutely. Always a risk versus benefit calculation.
Now, how do these drugs play with others? Drug interactions.
Always a critical check. Some common examples. NSAIDs taken with anticoagulants like warfarin significantly increase bleeding risk. Both affect clotting pathways or platelet function.
Yeah, that's a big one.
Definitely. Methotrexate combined with certain antibiotics, like trimethoprim, often found in Bactrim receptora, can increase the risk of myelosuppression problems with the bone marrow producing blood cells.
Also serious.
Yes, and corticosteroids taken with certain diuretics, particularly loop diuretics like furosemide, can increase the risk of low potassium levels, hypokalemia.
So keeping track of everything a person is taking is just vital.
Absolutely essential. And just a quick clinical pearl here, aspirin works a bit differently than other NSAIDs by irreversibly inhibiting COX-1 in platelets, which gives it its anti-clotting effect. Taking other NSAIDs concurrently might interfere with aspirin getting to that binding site, potentially reducing its heart protective effect if someone's taking low-dose aspirin for that reason, something to be aware of.
That's a really practical point. Okay, let's talk dosage and some clinical pearls practical advice.
Yes, for ibuprofen, as we said, doses vary, maybe 400 milligrams up to 800 milligrams, usually every 6 to 8 hours. There's a maximum daily dose, often around 2,400 milligrams or 3,200 milligrams, depending on guidelines that shouldn't be exceeded.
Okay, prednisone.
Prednisone dosage is highly variable depending on what's being treated. Could be low dose for a while or a high starting dose for an acute flare. But the key thing, as we mentioned, is tapering. If someone's been on it for more than a couple of weeks, you have to reduce the dose gradually to allow the adrenal glands to wake back up. Stopping suddenly can cause serious problems.
That tapering really stands out as important. Methotrexate for RA.
For rheumatoid arthritis, methotrexate is typically given once a week, not daily. That's a crucial safety point. Doses might range from 7.5 milligrams to maybe 25 milligrams per week, and regular monitoring blood counts, CBC, and liver function tests, LFTs, is absolutely mandatory.
Weekly dosing, vital monitoring. Got it. Any pediatric notes?
Yes, a very important one. Avoid aspirin in children and teenagers, especially if they have a viral illness like the flu or chickenpox, because of the risk of Ray's syndrome. It's a rare but potentially fatal condition affecting the liver and brain. Other NSAIDs like ibuprofen are generally preferred for fever or pain in kids.
Crucial safety tip for parents. Okay, what if things go wrong? Toxicity or overdose?
Right. With an NSAID overdose, you might see significant GI bleeding, perhaps acute kidney failure. Management often involves supportive care, maybe activated charcoal if caught early, IV fluids, trying to manage the complications.
Okay. Methotrexate toxicity.
Signs might include severe mouth sores, stomatitis, a drastic drop in all blood cell counts, pancytopenia. The specific antidote or rescue therapy is leucovorin. It's a form of folic acid that bypasses the step blocked by methotrexate, helping healthy cells recover.
So there's a direct countermeasure. That's good. What about aspirin, specifically salicylate poisoning?
Salicylate poisoning can cause ringing in the ears, tinnitus, rapid breathing, confusion, and a specific type of acid-based disturbance called metabolic acidosis. Treatment can involve trying to make the urine more alkaline to help excrete the salicylate faster, and in severe cases, even hemodialysis might be needed.
So different drugs, different signs of trouble, different management strategies.
Exactly. Prompt recognition is key.
Let's highlight some of the most serious warnings now, the black box warnings.
Okay. For most NSAIDs, except aspirin, there's a black box warning about increased risk of serious cardiovascular thrombotic events, heart attack, stroke. This risk can occur early in treatment and may increase with duration of use.
That's a major one.
It is. They also have one for serious GI bleeding, ulceration, and perforation. For the biologics, especially TNF inhibitors, a major black box warning is about the risk of serious infections, including reactivation of latent TB or new fungal infections. Screening is vital.
Infections again? And methotrexate.
Methotrexate carries several black box warnings, including potential for severe liver damage, hepatotoxicity, lung damage, pulmonary fibrosis, bone marrow suppression, and risks in pregnancy. It underscores why it requires such careful monitoring.
These warnings really drive home the potential seriousness of these medications.
They do, and maybe a high-yield fact to tie some threads together. The COX-2 selective inhibitors, while designed to spare the GI tract, generally carry a higher cardiovascular risk compared to some non-selective NSAIDs like naproxen, though it's complex. It wasn't a perfect solution.
That trade-off, again, it really highlights the need for individualized assessment.
Precisely.
All right, let's do a final run-through, a sort of checklist of the absolute must-knows about anti-inflammatory agents as we wrap up.
Okay, key takeaways. First, grasp the core mechanisms. NSAIDs hitting COX enzymes versus, say, biologics targeting specific cytokines like TNF-alpha. Big difference in approach.
That's right. Mechanism matters.
Second, know key drug examples and their prime uses. Prednisone, often for acute, severe inflammation. Methotrexate as a cornerstone for RA colchicine, specifically for acute gout flares.
Got the key players and their roles.
Third, the importance of monitoring cannot be overstated. Think LFTs and CBCs for methotrexate, blood pressure for anyone regularly taking NSAIDs.
Monitoring.
Fourth, be aware of specific toxicity management. Leucovorin rescue for methotrexate toxicity, maybe alkalinizing urine for salicylate poisoning.
Know the emergency plan.
And finally, remember key contraindications. NSAIDs are generally out if you have an active peptic ulcer. Biologics require caution or avoidance if there's active TB. Pregnancy is a major contraindication for methotrexate.
Crucial safety boundaries.
Yeah.
That's a really solid summary. We've definitely covered a lot of ground today, from the huge range of uses for these drugs, how we